My name is Tiffany Lowe, and I'm a second-year student presenting on granulomatosis polyangiitis, presenting with minimal symptoms. Granulomatosis polyangiitis, also known as GPA, is a rare small vessel vasculitis occurring in 13 out of 1 million adults with inflammatory reactions primarily in the upper respiratory tract, lower respiratory tract, and kidneys. GPA is idiopathic and autoimmune, and diagnosis is based on clinical symptoms, positive C-ANCA serology, and histological evidence of necrotizing. So the case was a 59-year-old male with past medical history of coronary artery disease, uncontrolled type 2 diabetes, stage 4 chronic kidney disease, and was referred by his nephrologist to the emergency department for urgent kidney biopsy because his renal function had declined by over 50% in the past year. Additionally, a month ago, he had a history of hemoptysis in the mornings lasting 1 week. His nephrologist referred him to have a chest CT, which found a nodule seen in the photo to the right. Consequently, he was recommended a lung biopsy. He denied any other history of upper respiratory tract or lower respiratory tract symptoms common to GPA, such as cough, epistaxis, ear or sinus pain, hearing loss, or saddle nose deformity. The patient denied any pain or physical complaints at admission. Patient had a previous history of several bilateral skin lesions on his legs of unclear etiology. This patient's lab testing revealed microhematuria and proteinuria along with positive ANCA, ANA, and PR3. Based on lab results highly suggestive of GPA, in addition to the presence of a lung nodule and right lung ground glass opacities noted on the CT chest, the patient was sent for lung and kidney biopsy for further workup. This is not the actual patient's biopsy on the left, but shows what the kidney biopsy revealed: post-immune ANCA-associated crescentic glomerulonephritis. The kidney biopsy also found moderate acute tubular injury, mild to moderate interstitial inflammation, and mild to moderate interstitial fibrosis. The interventional radiology team did not think the lung nodule was in a safe location for a CT-guided biopsy, and a diagnosis was made without a lung biopsy. After over a week of admission in the hospital, the patient was discharged and instructed to follow up with nephrology concerning the most likely diagnosis of GPA. So this case was unique because the patient showcased almost no physical symptoms. While the upper respiratory tract is the most common site of lesions in GPA, according to the literature, a lesion occurs in 70 to 100% of cases in the upper respiratory tract. The patient did not present with any signs of upper respiratory tract lesions. The only lower respiratory tract symptom was hemoptysis, which led the nephrologist to request a chest CT. The CT showed a right upper lung pulmonary nodule and right lung ground glass opacities consistent with GPA. Renal involvement was indicated by the glomerulonephritis. If the nephrologist had not noticed the rapid renal function decline, this patient would most likely not have been diagnosed due to the minimal symptoms, and early diagnosis is crucial for treatment of this disease. Given the patient's complex medical history, such as diabetes, high cholesterol, coronary artery disease, it was difficult to distinguish if a patient's clinical manifestation was due to a previously diagnosed condition or GPA. So for example, the patient had lower leg skin lesions that were previously attributed by him to his uncontrolled diabetes, but rheumatology considered past leukocytoplastic vasculitis. A key takeaway is that symptoms of vasculitis can overlap with the patient's complex medical history, so attaining a detailed investigation, including biopsy, labs, and other findings, are crucial to diagnosing GPA. Thank you for your time.